Okay, so this is another talk that Yasser asked me to give, and I had to do a lot of thinking about it. And this is the talk I've put together. And we really have to define what we mean by resistant lupus nephritis. And again, I'm just going to come back to the issue of adherence. I'm going to tell you about some new drug therapies, and then end with the great physician philosopher Galen, who explains everything for us. So this is an email that I get very often. This is one of the 10 mistakes I told you about. I have a patient with class 4 lupus on MMF for 3 months. Of course, no mention about the steroids, and still has proteinuria after 3 months. Should I give her rituximab? And I get this email or phone call a lot. And as I said, there's no mention about the corticosteroids, and it's too early to think about anything. So, as I said before, it takes a long time for proteinuria to get better. It may also take a long time for the renal function to improve. In fact, we've had people go onto our dialysis program, and about a year later, they recover renal function and are able to come off dialysis because of lupus nephritis. And in fact, the corollary is true too. If someone has an elevated creatinine that normalizes in 1 week, it probably wasn't lupus nephritis. It was probably acute tubular necrosis or something like that. So this is just a picture of a juicy, proliferative lupus nephritis to tell you it takes a long time for this to get better. And I showed you that, So as I said before, we shouldn't be escalating or continuing intensive immunosuppression just if the readout of this is the 24-hour protein. And one of my colleagues gave me a great motto. This is German, Adwarten und Tee trinken. Does anyone know what this means? Sit back and drink tea. Okay, so I think that's very wise advice. The other thing, too, you might think about if you ever happen to read studies of renal disease, given that it takes so long for the kidneys to repair themselves, is there's a lot of studies where patients get drug A, and then they have so-called non-response, and they get drug B, and they start to get better. And everyone assumes, and I wonder how much of the rituximab literature is like this, and everyone assumes that it was regimen B that made the patient better, but in fact, could it just be a slow response to regimen A? And this really bedevils me when I read studies of glomerular disease, because it can take a long time for it to get better, and we tend to credit regimen B, whereas maybe it was just a delayed response to regimen A. So I talked about resistance before, so I'm going to skip it. But especially for the question that was asked before, this is from the KDIGO guideline, and I think they're very important. Decisions to alter therapy should not be based on urine sediment alone. We talked about that. And the strategy of trying to convert a partial remission, i.e. subnephrotic proteinuria, whatever, to a complete remission by increasing corticosteroids or using other immunosuppressive agents is not supported by evidence. I think this is very important. Unfortunately, it's buried in the KDIGO guidelines, but I think it's very wise words. We do know that true resistant lupus nephritis is associated with a bad outcome. Actually, in any study of glomerular diseases, lupus or otherwise, it's usually that the complete remission have got the best long-term prognosis, partial remission has got a so-so prognosis, and no remission has got the worst prognosis. And as I said, it takes a long time. This is a whole different study from the ones I showed you before, but this is time until the patient went into renal remission, and you can see that how slowly it takes, and by the time that a lot of the patients are going into complete remission, it's over 3 years. So again, change your mindset to think about that it takes years, not weeks or months, for patients to go into remission. And this just shows again what I said, that people with complete remission do better than partial remission, who do better than no remission. This is a study that was spearheaded by Dr. Fortan, which looked at about 600 patients. First of all, only 6 patients went on to end-stage renal disease of these 600 patients. And this just shows that, of course, not going into remission was the main predictor of ending up with end-stage renal disease. And then when I was flying over here, I thought, oh, I forgot to mention about resistant hematologic stuff, not knowing that Dr. Mona was going to give a talk. So I did want to remind people about the hemophagocytic syndrome or macrophage activation syndrome as a cause of resistant hematologic parameters, because this is certainly something, again, that isn't much on the radar in adult medicine compared to pediatric medicine. So you heard a very nice review of this just now. So I talked about non-adherence as a major cause of true resistant lupus nephritis, and I told you again, if the patient doesn't look Cushingoid, if they're not filling their prescription, if they can't tell you how many pills that they're taking every day, and you know, you can't blame them. There's so many side effects. You know this better than anyone, and there's increased susceptibility to infection, all the psychobehavioral problems that we haven't even talked about, but can certainly impact quality of life, taking these corticosteroids. And it makes our patients miserable. And I think corticosteroids alone are a major cause of non-adherence to therapy. And I wonder, do they just stop taking their corticosteroids, or they stop taking all their medications? So I think that non-adherence, in my mind, is probably the #1 cause of true treatment failure or resistant lupus nephritis. There's very little of this in the literature. And so, you know, if you say patients not taking their medicine, is this resistant lupus? Okay. So what do you do about non-adherence? As I said, I don't know. You can do pill counts, you can call the pharmacy, you can quiz the patient, you can do drug levels of, for example, mycophenolate or cyclosporin. Like I said, minimize the number of pills. I just see so many of my colleagues have a brand new 22-year-old lupus patient without a drug plan, and they prescribe the prednisone, the MMF, and I'm going to give you a proton pump inhibitor to help your stomach, calcium, vitamin D, Ceftra for pneumocystis prophylaxis. I'll give you a statin for your lipids, and this antihypertensive, and all of a sudden you're giving a 22-year-old 8 different medications, and I'm terrified that they're just going to, you know, freak out and not take any of them. So minimize the number of medications that you give the patient. And if you're truly worried about non-adherence, I think intravenous therapy is not a bad second option, including cyclophosphamide. And like I said, at least you know whether the patient got the medication or not. So for true resistant lupus nephritis, what are the new therapies that are coming down the pipeline? Well, KDIGO, for example, recommends if the patient's on MMF, switch to cyclophosphamide, and or vice versa. And this was also agreed on by the Americans and the Europeans. There's really no evidence to support this. I showed you about the drug A and drug B thing. So I don't know sometimes if you switch from A to B and the patient gets better 18 months later, was it that slow response to drug A? I mean, you never really know. And as I said, I have done in the past is if I've had a patient on MMF, which they have to take at home, and I don't think they're taking their medications, it's not a bad reason to give them, for example, a Eurolupus trial of intravenous cyclophosphamide, just to know that they got some medication. The calcineurin inhibitors probably reduce proteinuria by A, decreasing afferent arterial perfusion, and B, by changing the podocyte, which is the regulator of how protein crosses the glomerulus. And this is a very nice review. This is a podocyte, which is that interesting part of the glomerulus that sits on top of the basement membrane and regulates how much protein can cross. And probably the calcineurin inhibitors work by stabilizing this podocyte, which restricts the amount of protein that enters the Bowman's space. So this has nothing to do with immunology or lupus treatment itself. It's really just a way to mechanically, if you like, reduce proteinuria. So I think that the main use of calcineurin inhibitors is just really to reduce the proteinuria. And as I said, I'm not absolutely convinced that these drugs treat lupus immunologically. So I restrict their use really to people with membranous lupus who have symptomatic nephrotic syndrome. I'm not talking about someone who's got 3 grams, no edema, serum albumin that's pretty reasonable. I'm talking about someone who's miserable with 12 grams of protein, anasarca, and so on. It's also used by our high-risk team as an antiproteinuric drug in pregnancy because you can't use ACE inhibitors or ARBs, so our pregnancy nephrologist uses cyclosporin to reduce proteinuria in the pregnant patient. So what about rituximab? Because again, you know, if cyclophosphamide is really bad for you, it must work great, and if a drug is more expensive, it must work great, right? So you heard a little bit about rituximab before. The LUNAR study was a negative study. This just showed the protocol of the study, and there was no difference in the significant endpoints, although the lupus serology, for what it's worth, was better in the rituximab group. And then again, because microhematuria is a lousy way to measure response, my colleague Brad Roven actually took out microhematuria as a response indicator, but it still made no difference. Rituximab still didn't come up any better as an additional therapy in the LUNAR trial. What about, we're talking about different sort of treatments for resistant lupus nephritis. What about plasmapheresis? You would think this should work. This should be a great treatment. And in fact, Ed Lewis did a randomized controlled trial in the United States where he used plasmapheresis for patients with severe lupus nephritis, and it didn't work. It was a negative study, and that really basically quashed plasmapheresis as a treatment for severe lupus nephritis. And then I've just done a literature search, and I've kind of looked at the new things that are there. Bone marrow ablation and reconstitution. You heard about leflunomide, IVIG, the different monoclonal antibodies, ACTH, and ACTH is kind of interesting because it's supposed to work in a way that's different from the fact that it just stimulates cortisol production. It's supposed to have a unique mechanism of action, and some people, in fact, are using it for primary membranous nephropathy, not lupus, but primary membranous nephropathy. And also the so-called new small molecules are all in early phase studies to see whether they're going to work, but there's really nothing out there. You're not missing on any kind of great breakthrough that I could find in the literature. So far, no magic bullet for truly resistant lupus nephritis. And I want to wrap it up just with an explanation by Galen. So, who was Galen? He was a Greek physician who wrote a book called That the Best Physician is Also a Philosopher. And he said the following, Galen's hypothesis: all who drink of this remedy will recover in a short time, except those whom it does not help, who will all die. Therefore, it is obvious that it fails only in incurable cases. Or to paraphrase this, everything works in mild disease, more or less, and nothing works in bad disease. And I think, you know, he lived 2,000 years ago, and it's just as applicable now. So wait at least 6 months before declaring that lupus nephritis is resistant. As I said, you've got to readjust your mental timeline for this. I think the main cause of truly resistant lupus nephritis is non-adherence. Parenteral treatment may be helpful for that kind of patient, because at least you know that they got the drug. And so far in 2015, there's no magic third-line treatment for truly resistant lupus nephritis. Thank you.
Any questions? I guess I just want to thank all the speakers. I don't know about the audience, but I had a good time and I learned a few new things. And thanks you also for attending. Thank you very much.